Good evening, everyone. This is a great opportunity for all of us to learn about some new insights and also to refresh our existing knowledge about some of the very important topics in retina. So, today's topic is about proliferative vitreoretinopathy. We have with us a renowned surgeon, Dr. Sunil Ganekal, who is the clinical head, Davangiri Netralaya. He did his Vitreoretina Fellowship from Shankar Netralaya and Oculo-Oncology Fellowship, New York Eye and Ear Infirmary, Research Associate, Mayo Clinic, USA. He has been the Chairman Scientific Committee of Karnataka, Editor-in-Chief, Karnataka State Journal. He has published more than 50 publications and is also the reviewer of many prestigious journals like AJO, BJO, BMC, Retina, JAPOS, and JCRS. We would like to welcome you, sir. Over to you for the talk.
Thank you, Roshni, for the kind introduction. Basically, today I'll be talking about one of the common complications which are associated with rheumatogenic retinal detachment, that is proliferative vitreoretinopathy. I will basically divide my talk into two aspects. One is how the proliferative vitreoretinopathy develops and what are the implications. And the second part will be the surgical management of proliferative vitreoretinopathy. As you know that basically what happens once the rheumatogenic retinal detachment occurs, there will be fibrocellular proliferation in patients with rheumatogenic retinal detachment, resulting in cellular reaction. Usually what happens post detachment, there will be healing process which occurs, but it's an abnormal healing process of the vitreoretina which occurs because of the cellular proliferation, which leads to certain complications. I'll be telling you what are the complications associated with this. So what is the incidence of this proliferative vitreoretinopathy? Typically, as the literature says, you tend to see this in 5 to 10% of all rheumatogenic retinal detachments. And invariably, this is one of the commonest cause for the failure of the retinal detachment surgery, which is seen in as high as 75% of the cases post-eye surgery. It tends to be typically highly aggressive. PVR tends to be highly aggressive in pediatric age group as well as the young patients. And PVR is one of the commonest cause for the poor functional outcome in a patient with rheumatogenic retinal detachment. In many other patients, you may get a good anatomical outcome, but the functional recovery will be poor basically due to the apoptosis which occurs and causes the damage. The second thing is long-standing RDs with PVR tend to have a photoreceptor degeneration. So in spite of anatomical reattachment, you tend to have a poor visual recovery post-detachment. So as you told, there will be a cellular components which are contributes for the development of these membranes. So what are these cells which are typically contributing for this development of this PVR? The most important things are the retinal glial cells. As we know, the glial cells mainly consist of Muller cells, astrocytes, and microglial cells. And the second and the most important cell being the retinal pigment epithelium. Hyocytes also contribute. Sometimes the ciliary body epithelial cells, the blood-borne inflammatory cells, fibrocytes and myofibrocytes, all these contribute for the detachment. As you can see in this the picture, once the retinal detachment occurs, there will be ischemia as well as inflammation, which in turn leads to the apoptosis, followed by a cellular proliferation, migration, and transformation. Ultimately leads to a scar formation, what we typically call it as a PVR membranes. So this is a sequence of events which occurs over a phase-by-phase manner, depending upon the etiological causes, and leads to the formation of a proliferative membranes on the vitreous retinal surface. As we all well aware that the vitreous is part of any cellular components. The only cellular component which is present in the vitreous is, except the few hyocytes are seen. As you know, the vitreous is very well protected from outside by the two things. One is the protective internal limiting membrane. The other thing is the blood retinal barrier. Any breach in any of these two components leads to RPE cells, which migrates from the into the subretinal space, subsequently into the vitreous, and causes the changes in the vitreous as well as on the pre-retinal surface. So basically, you tend to see an inflammation, cellular proliferation, and extracellular matrix remodeling. All these causes the changes, pathophysiological changes, causes the formations of the membrane on the surface of the retina as well as the vitreous changes. But as I told, the most important cell which contributes for the PVR is the retinal pigment epithelium. This is the major cell involved. The one important pathophysiological change one should remember whenever an RP is released, it undergoes something called as an EMT. What is an EMT? That is an epithelial mesenchymal transition. That is, RP cells from a physiological states, morphologically they change into mesenchymal cells and fibroblast like cells. leads to they develop a contractile properties and the fibrosic properties, so that there will be development of fibrotic membranes or the scar on the surface of the retina as well as the vitreous. So this transformation of the RP is very key in the development of PVR. As I told before, as soon as the regmatogenous RD develops, cytokines leaks into the subretinal space, which in turn cytokine stimulates the RP cells. Once the RP cells are stimulated, they tend to lose the intercellular adhesions which are present. And the most important mechanism which occurs in the development of PVR is known as what is known as epithelial mesenchymal transition. That is the most critical thing which is required, which in turn leads to the proliferation and migration of these cells into the vitreous as well onto the retinal surface. The second most important cell which contributes for the PVR apart from RP, I told the Muller cells, the microglia, fibrous astrocytes. As you know, these are the which keeps the integrity of the blood retinal barrier, supports the neuronal activity in the retina. For the ionic and the osmotic homeostasis, these are the cells very, very critical in the retina. But in RD with PVR, what happens? These glial cells undergoes hypertrophy. There will be upregulation of something known as vimentin on the surface of these glial cells, which in turn leads to the cellular proliferation, the gliosis. The glial cells, once develops in PVR, tend to replace the dying neuronal degenerative axons. So mechanically, there is an obstruction for the normal regenerative process of the axons once the PVR process occurs. Of course, the blood-borne inflammatory cells also contributes for the PVR. As I told, the macrophages circulating fibrocytes are the precursor of myofibroblasts. The ionocytes have a role in the synthesis of extracellular matrix and the modulation of inflammation. So because of these contractile properties, ionocytes also contribute for the development of PVR. As I told pathophysiology very clearly, there is an RP cell migration and proliferation and an important epithelial mesenchymal transition, what we call EMT. Then there is a membrane formation, retinal cell death, and later on it leads to the membrane contraction and the fibrosis. All these changes sequentially leads to the complications in PVR. There are very many growth factors which have been described with interleukins like platelet growth factor, transforming growth factor, even the VEGF party, interleukins, the fibroblastic growth factors. All these typically collectively contribute for the formation of this in the pathophysiology of the PVR. Like biomarkers, we have certain biomarkers for the patients with PVR. As we know that the matrix metalloprotein is concentrated, which is very increased in any cases with inflammation where the vitreous concentration is raised. Even the chemokine concentration. Inflammation is associated with increase of certain protein like alpha-1 antitrypsin, apolipoprotein pre, and the transferrin. These are some of the biomarkers which tend to see in the PVR. So once you see a patient with retinal detachment, what are the risk factors which causes the PVR? The trauma is the most significant factor which causes the PVR. So the traumatic cases are the more prone to PVR than the other regmatogenous retinal detachment. Chronic detachments causes the PVR. Any previous history of PVR further aggravates the condition. Uveitic conditions, there is an inflammation. If patient has got an associated choroidal detachment with PVR, the RD, then the risk of PVR definitely increases. So then failed RD surgery, if you have done a primary surgery which has failed, it goes for a PVR changes. Multiple retinal surgeries, repeated vitrectomies, especially with MIVS, it's not a concern now. But when the era of 20 gauge vitrectomies, when we do multiple retinal surgeries, probably the incidence of PVR used to be much more. Intraoperatively, if you do a procedures like large retinectomies, excessive cryo, extensive laser for the retinal breaks, injection of air, all these are the risk factors. Aphakics have got a more risk for PVR than the pseudophakia. If the patient has got an associated vitreous hemorrhage along with the detachment, it is another high risk characteristics. Retinal tear, any tear which is more than 3 dash diameter has got an increased risk of PVR because of the larger exposure of the retinal pigment epithelium. Typically, you tend to see the such tears in a giant retinal tear where the exposure of the RP and other things leads to the development of extensive PVR. So you should look at all these risk factors, which gives a clue that these are the patients which need to be tackled early or has to be intervened early because to prevent the PVR changes. So it has to be operated as early as possible. Is there any method by which you can quantify the PVR? Especially there is an article by Asaria which was published way back in 2001. They modulated a predictive score for the PVR. Like for example, if the patient has got an aphakia, you have to increase the scoring by 2.9 to multiply it by, so it gives, if a grade C PVR 2.88, like grade P PVR, anterior PVR, the number of quadrants of cryotherapy. These are the values which you multiply. So what is the implication of this? If the cumulative score of this, all these aggregate together increases more than or equal than 6.88, these are the high risk patients who are going to develop a post-op PVRs. So doing a clinical trials also, you can get this the score them to assess the risk for post-operative PVR. This is one of the useful assessment tool for assessing the high-risk characteristics. So how to diagnose a PVR? If you see a patient with a rhegmatogenous retinal detachment, early stages, very subtle changes, you may not see much. There may be retinal wrinkling on the surface of the retina. There could be mild vitreous stage with cellular dispersion. The vessel tortuosity and small wrinkles and fixed folds can be seen. If these fixed folds are adjacent to the retinal breaks, you can see the post edge of the tear, there will be rolling of the tear edges. So this is one of the clues which says that patient is developing an early PVR. Of course, with an advanced PVR and extensive PVR, tend to see a fixed retinal folds. This PVR typically tends to develop in the inferior quadrant more than any other quadrants. There will be bridging value of the membranes can be seen. The retinal shortening can be seen, decreased retinal mobility. If this extensive PVR further progresses, one may develop a closed funnel retinal detachment with equatorial membranes. Suppose somebody develops some PVR in the anterior part of the retina near vitreous base, there will be contraction of the vitreous base, which pulls the ciliary body. Sometimes it detaches the ciliary body and the ora serrata and causes the cyclitic membranes also. So you tend to have an hypotonia and other complication if there is an associated anterior PVR. There are various classifications which have been described for the PVR, but no classification of is PVR without flaws. This is one of the older classification described way back in 1983, which graded them into A, B, C, and D classification. And this A means early stage, B means in only inner surface involved, C means full thickness retina is involved, C based on the quadrants, and if they develop a funnel RD, D and E category was used in this retina society classification. But one of the drawbacks of this classification was it ignored the epiretinal proliferation which develops anterior-posteriorly, and some of the results, if you see, they claim that inactive grade D PVRs did better than grade C PVR, which is, if you look at today's scenario, it's something which is unacceptable. So this classification was not followed further, and further modifications were done in this classification. Then the revised classification came back way back in 1991 based on the location, extent, and the severity of PVR. In that, the grade D was removed. A, B, C. CP means posterior. CA means anterior. This is based on the number of clock hours. We divided it into 1 to 12. A and B stands the same, but in the posterior, if the PVR develops posteriorly, it is CP. If it develops anteriorly, it is called as an anterior PVR. These are some of the PVR examples: grade A, grade B, and grade C PVRs. So this became a much more useful classification for the management of the PVR. Of course, based on the morphology, the posterior PVR can be either focal, that is a star fold posterior to the vitreous base, or it could be diffuse PVR, sometimes subretinal PVR, circumferential, and anterior. These are the two anterior PVRs you need to see in patients with a proliferative vitreoretinopathy. The subretinal PVR could be any shapes. It could be in the form of an annual ring around the disc. It could be a linear strand subretinally, or it can be a napkin ring around the disc completely 360 degree. The circumferential, of course, develop at the edge of the vitreous base and causes the central displacement of the retina. The anterior PVR also base pulled anteriorly leads to ciliary body problems and detachment and complications. Now coming on to the management of PVR, there is no medical line of management as such, some purely surgical management. So how to manage a patient with PVR is basically you should clinically assess them and to see the grade and severity of the PVR. You should look at the type of contraction, whether it's a focal, diffuse, or subretinal in the posterior PVR, or circumferential, perpendicular, and anterior in anterior PVR. This gives a clue to that what is the mechanism, what is the intraoperative modifications one should do to get a good outcome. Then of course the location, whether it is a posterior or anterior, look at the high risk factors which I described earlier. Look for signs of inflammation like vitreous haze, associated choroidal detachment. take a proper history of previous vitrectomies, which gives a clue to that. So these are high risk characteristics you should assess. Goals of management of PVR, I typically call them as 3 Rs. What are the 3 Rs of management of PVR is, one is anatomical reattachment, reattach the retina. Relieve all traction. This is the most critical step in a management of PVR. That is, you have to really relieve, peel all the membranes to make sure that all the traction is relieved from the retinal surface to proper alignment and proper attachment occurs. And relieve the foreshortening. If there is a contracture of the retina, by maneuvers like retinectomy and other things, you should cause this foreshortening and to allows the anatomical reattachment. So reattach, relieve all traction and relieve foreshortening. Basically, when you tackle any PVR, either you can do it either by scleral buckling or by vitrectomy. When to consider scleral buckle in PVR? Of course, any young and phakic patient with a PVR, always give a trial of scleral buckling rather than ending up with vitrectomy straight away. Then if the PVR is confined only to the grade B, C1 and C2 with an anterior break, which is buckleable, then consider the options of scleral buckle. Vitrectomy, definitely yes, if it is a grade C3R and above, and aphakia, pseudophakia, no evident breaks on clinical examination. Break is quite posterior to do a scleral buckling. Failed scleral buckling and recurrent RD, some of the indications for vitrectomy. Some cases you may have to combine both vitrectomy and scleral buckle based on the clinical scenario. So typical steps of any pass plan. First is a PVD induction, which can be done very easily with the use of transluminal. Removal of all membranes, peel from the face, from the posterior using a forceps pick, membrane spatula, or any other accessory instrument you can use. And staining is a very useful technique, especially when membranes are indistinct and you're not able to see them properly. You can stain them with brilliant blue. Sometimes you may have to resort to the bimanual maneuvers because of the peeling can extend quite anteriorly. So subretinal membrane removal, which I will be showing the video subsequently. Relieve all retinal tractions. And PFCL is definitely a useful tool in patients with PVR, especially for membrane removal, relieving tractions, posterior pole stabilization, and prevent the bleeding or attaining an homeostasis in a patient during vitrectomy. Let me show you a video. This is the first case, is a case of a posterior PVR, the membrane being peeled from the surface of the retina. Keep a close watch on the retina when you're pulling the membranes. You should not pull too hard. You can easily grasp, and the staining definitely helps in peeling of all these membranes, especially the patient with a posterior PVR. I tend to peel the ILM in most of the cases with posterior PVR, arcade to arcade, because it prevents the recurrences of the PVR. Next is a case of a subretinal linear band removal. You have done a retinotomy, hold with the end grasping forceps. Sometimes it comes as a piecemeal. So go through the retinotomy, pull it. Sometimes you can make a multiple retinotomies if you can't remove the membrane in toto. But make sure that try not to enlarge the retinotomy as much as possible. Make an retinotomy adjacent to the bands. This patient had a posterior as well as anterior subretinal bands. And anteriorly also retinotomy being created for the removal of the subretinal bands. Sometimes if the subretinal bands are diffuse and extensive, you may have to do a retinectomy. Cauterize the area of the retina to cut the retina to create a retinectomy with the cutter. So once you have done that, here the hemostasis is very critical, otherwise it will bleed very heavily in such scenarios. Roll the retinal surface, go back to the back surface of the retina, and you can peel the diffuse sheet of subretinal membranes. It will give an easy access to the multiple membranes which are on the back surface, and you can clearly, under direct visualization, here the bimanual maneuvers definitely helps. You can see that the chandelier being used and the bimanual maneuvers, you can use this in this. And you can use a PFCL to roll back the retina and laser the edges of the retinectomy. Try to avoid 360-degree retinectomy as much as possible. Sometimes it can lead to the displacement of the fovea and the macular rotation. So once you have done that, you can do a PFCL silicon oil exchange and do the endolaser to the edges. Sometimes not doing a retinotomy also, you can go transclerally without creating a retinotomy in the subretinal space through the posterior trocars. You can go directly subretinal space, No retinotomy being created. You can grasp the subretinal band and you can remove it transclerally also. But this procedure carries the risk. You may damage the choroid sometimes. This is done transclerally, means be going under the retina without creating a retinotomy. No retinotomy being done in this case. So you can remove it transclerally also. This is how the well-attached retina you tend to see it. So as I told, sometimes you may have to, if the lens is opaque, you may have to do a phaco along with vitrectomy. Or if the patient is young, you may sometimes end up with a lensectomy or IOL removal if there is a capsular fibrosis and optic capture and other things. If cornea is opaque, you may have to resort to temporary keratoprosthesis. So you can combine both PK as well as vitrectomy. If you got an access to endoscopy, definitely that's a useful tool for assessing the operability of the cases, whether to abandon the cases and other things. ILM peeling, definitely yes. You can use the brilliant PFCL for peeling of ILM. Retinotomy, do it with an endodiathermy, subretinal band removal I showed, and that same retinotomy can be used for the SRF drainage. Retinectomy, I consider it as a last resort. To relieve the retinal shortening or a retinal contracture, one should do a retinectomy. But make sure that you should completely remove all preretinal membranes, especially the retinectomy is very critical when you are doing and dealing with anterior PVRs. But try to avoid 360-degree retinectomy if possible. But some cases in a closed funnel RD like scenario, there is no alternative. You have to go with a 360-degree retinectomy. Sometimes what happens if the patient has developed a recent onset of PVR, especially in recurrent RDs, sometimes you tend to wait for some time because it allows the maturation of the membranes. Thin membranes and immature membranes are sometimes difficult to grasp and peel. So you need a close observation to see when to operate these recurrent RDs in a patient with a PVR. When to use scleral buckling or an encycling band or a 240 band is, one is, the purpose is it supports the vitreous base and relieves the traction, relieves the foreshortening of the retina. Anterior PVR, definitely yes. If you anterior PVR, you cannot peel it completely, and if you left over some membranes, you can do an anterior, supporting with the encircling band or a scleral buckle. And sometimes if you missed an intraoperative peripheral breaks, this buckling supports the peripheral breaks and it allows the chorioretinal adhesion. Tamponade, it's of your choice. If it is an early PVR, gas is definitely an option. Silicone oil, if it is on one eye, you can go for an heavy silicone oil. 5000 centistokes also you can use it in selected cases. But choice should be individualized based on the patient-to-patient basis rather than generalizing the thing. Coming on to the adjunctive therapy. So you plan for a vitrectomy. Any adjunctive treatment will help prevent the recurrence of PVR or improve the outcome. Let's look at some of them. Oral steroids, definitely yes. If you're associated with the choroidal detachment and other things, sometimes the patient is intolerant to oral steroids. You can give a subcutaneous triamcinolone acetonide also. You can give an intravitreal triamcinolone during intraoperatively, especially at the edges of the RR and other things, to prevent the developing PVR at the edges of the relaxing retinotomy. Ozurdex, definitely an option. 5-FU and low molecular weight heparin also have been used. But recently, there are a lot of been articles on the usage of intravitreal methotrexate in patients with PVR. I published the article way back in 2013. We used basically 5-FU and low molecular heparin, especially in high-risk PVR patients. We didn't find much improvement with any of these adjunctive treatments with 5-FU or low molecular heparin with respect to the anatomical or functional outcome. So not much use with the 5-FU or low molecular weight heparin. This is a patient with PVR with an intravitreal Ozurdex which have been given. This I presented in the American Academy way back in 2019. The Ozurdex really helps in reducing the inflammation. And the most important thing is the Ozurdex, if you use in patients with PVR, especially helps in improving the functional outcome because it reduces the chances of cystoid macular edema post-operatively. So Ozurdex, to an extent, will help in high-risk cases. Is another case patient with an inflammatory RD almost nearly closed funnel with our RR edges. You can see clearly there is a fibrosis which is developing at the edges of the RR. In these patients, there are 4 to 5 intravitreal methotrexate injections were given which prevented the recurrence because inflammatory RDs are the more prone to develop this recurrent PVRs and cause the failure of detachment surgery. So intravitreal methotrexate definitely could be an option, especially in PVRs. There are various agents which you can use: corticosteroid, triamcinolone, prednisolone, dexamethasone, methotrexate, low molecular weight heparin, 5-FU, mitomycin. People have used ranibizumab, bevacizumab, as well as the aflibercept in cases with PVR also in animal studies and all. But you should take it case by cases based on high-risk cases. You can definitely consider these agents. Why these patients with high-risk PVR tends to have a poor outcome is, one, they tend to develop an intraoperative bleed. As I told, during doing retinotomy or retinectomy, you tend to have a bleed. Sometimes the regrowth of membranes occurs, and the recurrent RDX risk is as high as 30 to 50%, especially in high-risk cases. Macular pucker can be seen in spite of good attachment, which causes poor functional outcome. Hypotony, especially associated with anterior PVR, ciliary body detachments, and other things, you tend to develop an hypotony. So one should be very careful and keep a silicone oil for a much longer period in such patients. Rubeosis iridis, especially recurrent persistent RD post PVR surgery, you can develop a neovascular glaucoma, the rubeosis iridis, which is causes a painful eye. Then risk of phthisis, especially very high risk of PVR and high risk cases, one may develop a phthisis bulbi. So in conclusion, the outcome in PVR basically depends upon the location, severity of the PVR. Anterior PVR tends to have a much poorer prognosis when compared to the posterior PVR. Profound vision loss can occur in these patients in spite of good anatomical success. Poor results are seen with multiple surgeries, so one should take a proper history before planning. So planning is very, very critical in these PVR patients to how to go ahead and what is the planning of surgical procedure to get a good optimal outcome. Thank you for your patient hearing.
Thank you so much, sir, for that elaborate discussion. I have few questions. This PVR itself means difficulty, but I just wanted to know, sir, whether retinectomy you would advocate as part of the primary surgery or as part of a secondary procedure. Like you assess the attachment of the retina, you figure out in case of a chronic closed funnel RD.
Yeah. See, anterior PVR membranes which are not, you're not able to peel the membrane to the anterior part of the retina. And if the anterior PVR cannot be properly relieved, then definitely to settle the retina, you have to resort to retinectomy only.
So next, my question would be like, what is the role of preoperative steroids or oral steroids in the management of PVR?
PVR per se, I won't use it. If the patient has got an associated choroidal detachment, lot of vitreous hairs and other things, definitely you can use either oral steroids or a subtenon steroid. Both can be used. Unless there is no contraindications for oral steroids. Yeah, go ahead, Roshni. Yeah. That's what, if there is a vitreous haze is there and choroidal detachment is associated with RD with PVR, definitely I will give an oral steroids or a subtenon steroids. Otherwise, plain simple RD with PVR probably may not give an oral steroids.
Sir, next, I have a question on clinical decision making. Like, there are certain cases of chronic RD with PVR which may not
Okay.
benefit a surgery. So,
Okay.
patient RD surgery and yeah.
Yeah. See, the chronicity of RD, the outcome, especially in a pediatric age group, definitely I will give a trial. However, the chronic RD it may be, because it's a very, very critical to get an anatomical reattachment, and whatever the ambulatory vision, if a child gets, it's for more use. But in an adult and reliable patient, if there is a very long-standing close funnel RD, if there is an inconsistent perception of light and other things, probably you can defer the surgery.
Do we have any clinical features that would suggest that this patient may not, like for example, a patient with mature cataract and RD on B scan and having, we RD surgery. Do we have any certain clinical features to decide upon?
See, one thing is the B scan gives a configuration of the RD, one clue. The second thing could be in a mature cataract with RD, my plan always will be whatever may be the B scan my findings, I will do a lens aspiration or remove the cataract, do an indirect ophthalmoscopy intraoperatively to decide whether to go ahead with an RD surgery or just to defer the surgery. So you can't go by the just by the scanned reports whether to further proceed with the surgery or to defer the surgery.
Yes, sir. Correct. So, how long do we continue the post-operative steroids for the patients who have had PVRRD?
I don't give unless it's a pediatric RD and extensive retinectomy has been done, or an inflammatory RD is there, like post acute retinal necrosis RD or some other things. Per se, for a simple, straightforward PVR RD, I don't give oral steroids post-operatively. Topical steroids are more than enough to take care of the things.
Operate a case of RD and the patient develops PVR post-operatively under silicone oil or under a
Okay.
tamponade, under
Okay.
silicone oil, how early would you recommend to operate again? Resurgery in such cases.
See, one thing is there, the one is the macular status you should assess. The degree of detachment you should see. If there is a fixed particular 3, 4 folds and other things, you can observe also under the oil. If there is a significant detachment with a macular involvement, definitely you should go and operate as early as possible.
Yes, sir. And as you said, the role of ILM peeling is definitely important if we have posterior breaks, or would you advocate in all cases of PVR-RD, sir?
See, we are more concerned about the macula. The why I feel any posterior PVR, there are ERMs, there is always a risk of recurrent membranes. So better to peel an ILM in all these cases. So Preethi is asking when you call it as a recurrent RD.
Recurrent RD,
See,
yes.
anything which develops in a shallow detachment, classification of a rhegmatogenous retinal detachment with an untreated break or a new break with a detachment, it's a redetachment. It could be on a first post-operative wake or later also. So since you being the primary surgeon, you know which are the breaks which you treated, what are the intraoperative findings. If your patient develops a new break and you have sealed all the pre-existing breaks, definitely the patient has developed a PVR related RD. Sometimes the surgical technique itself can cause a recurrence. You might have not missed a break or something like that, then it can cause a recurrence.
Sir, often there is a
Hello?
missed sheet of vitreous also, especially in young patients who have had, who are myopes and have a adherent hyaloid, which gets missed. So staining with triamcinolone seems to be, and rather staining with BBG as well helps us to confirm the complete absence of vitreous, isn't it?
Usually I check twice. First I do it triamcinolone and then I use a brilliant Fuji. Both I use sometimes. And definitely the membrane scratches or the finesse loop, or there are many things which are available nowadays which helps us to get a plane of the PVD induction, especially in young patients. Definitely with a cutter it may be difficult sometimes, but you will get a cleavage plane with these additional surgical techniques.
So, do you advocate Thanos forceps, like the forceps that is used to identify thin, early, immature PVR?
Thanos membrane scraper, if you got an access, definitely yes. You can use simple like a Prolin suture also can be used. Make it a loop, tie it around, and I had a video but probably couldn't show here. You can peel the membranes. You can get a plane out of that also, because finesse loop sometimes may not be available with everyone. But the membrane scraper and loop both are definitely useful tools if you can't get a cleavage plane, especially if it is a thick adherent hyaloid. Definitely both these helps.
There is somebody online who is wanting to ask a question.
Yeah,
I
please
think
go ahead, please.
Dr. Roshni, there was one doctor, somebody had put up their hand. Are they
Yes,
still there?
please. Yes,
Yeah, please
please.
go
Good
ahead.
evening. Hello.
Yeah, you're
Please go ahead,
audible.
sir.
Please
Please
go
go
ahead.
ahead.
Yes,
Uh,
yes, sir. Thank you so much for the good presentation on PVR. I
yeah,
have one
please.
question. That I need. I have one question. You talked about the stages, like in stage 4, where you talked about the funnel shaped when you cannot see the optic disc.
Yes.
Do you go on still? You have to do the surgery, and if yes, how is the prognosis after that grade 4 PVR surgery? Through your experience, how if you do the surgery on PVR stage 4, what is the prognosis, maybe of the visual prognosis after?
Yeah, the one thing is sometimes what happens, the closed funnel configuration may be due to the equatorial membranes alone. There may not be much changes around the disc. Such cases
Yes,
definitely do well with just you pick up the membrane and suddenly funnel gets
yes,
opened up. So it depends from case to case. It doesn't mean that both the leaves of the retina is attached in a closed funnel configuration. It's the line-like configuration on a B scan. Closed
yes,
configuration, what did we call it as? Otherwise, the open close configuration does do well. Close
yes.
definitely may not do well with the vitrectomy that much.
All right, all right. Okay, thank you.
Sir, how do you assess the adequacy of RR, retinectomy in PVR
See,
cases?
most of the times I do RR under PFCL. So you tend to see a little layer by layer, the flattening of the retina. You tend to know where to stop and when to, how large you should do a retinectomy. That will give a clue to that. But make sure that why retinectomy is adequate, and you should be very sure is, suppose if you do an inadequate retinectomy and do a fluid air exchange, you end up with most of the times with a subretinal PFCL or a subretinal air. So make sure that before doing a retinectomy, you have peeled all the pre-retinal membranes first. Then only you should attempt a retinectomy. There is no point in doing a straight away going to retinectomy without tackling these pre-retinal membranes. So the pre-retinal membrane should be absolutely stained. You should be doubly sure that you have peeled all the pre-retinal membranes. Then only land up with go ahead with a retinectomy. And sometimes, as I told, the high height of the buccal can allow you to get away, but without doing a retinectomy also. So the buccal does play in some of the cases.
Sir, when do you advocate a buccal removal, sir, in patients who have recurrent retinal detachment with anterior contraction of the retina?
Usually, if it is a well-done buccal, I don't remove it unless there is an indication of a buccal infection or a buccal exposure or a suture exposure. Then probably we remove the buccal. Otherwise, there's no need for buccal. Why you want to remove the buccal?
Sir, there is a question in the group that is there any tip for any particular, for a beginner or a young surgeon, that on seeing these clinical signs that I can attempt a surgery or I should refer it on the first go on seeing any sign of PVR, like a subretinal band, a long-standing inferior RD or something like that?
See, one thing is there are critical things are, one is a closed funnel, definitely for a beginner, say no. And extensive, see, and the pre-retinal membranes are difficult to tackle. Sometimes for a beginner, extensive diffuse subretinal bands, such cases, they may not be able to handle. The anterior PVRs, definitely difficult to handle. Posterior PVR, early PVR, fixed star folds, if you can see, and you can definitely go ahead and do the cases in the early cases. And later on, as you become expert in managing these membranes, then you can go ahead with the advanced cases.
Thank you, sir. And there is a group that advocates methotrexate infusion to prevent PVR or to tackle patients with PVR RD. So, what's your take on that?
IV method, intravitreal, definitely yes. You mean to say intravenous?
Sir, intravenous, yes.
So intravenous methotrexate usually I don't recommend because it causes a lot of toxicity, especially the nephrotoxicity is quite high with these things. Definitely intravitreal, you can repeat any number of patients. The one case which I showed, almost I had given 6 to 8 intravitreal methotrexate post-operatively. So intravitreal methotrexate is well tolerated. It doesn't have any systemic side effects or anything, unlike intravenous. So the probably better to avoid intravenous. Intravitreal, definitely yes, you can use it.
Sir, how often do you repeat, like during the post-op period?
4 weeks, 6 weeks, you can repeat it. But based on the clinical scenario, sometimes I give one, look at the response. If there is retina maintaining, probably I delay the giving the injections also.
Okay.
But we had used infusion associated. We had injected in the intravenous bottle, the vitreous infusion. What we have used the low molecular weight and low molecular weight heparin and 5FU. We had used in the infusion bottle, and we did a study way back 10-12 years back. But that didn't give any better results when compared to the straightaway vitrectomy. So we stopped that study, and it got published, but we didn't get a good outcome of that study with that study.
Yes, sir. Is there any other questions for sir, like on handling PVR and RD?
One dictum I would like to say in a pediatric RD is, however severe may be the PVR, but give a trial of buccal. I still remember my learning days when I was just finished my fellowship. I operated on a 2-year-old child, which was almost a grade C severe PVR. I didn't want to enter the eye in a 2-year-old child. I just used a 240 band and the RD got settled. So any pediatric age group with a clear lesson and other things, don't hesitate to give a trial of buccal. It's not that you should land up with a vitrectomy in all the cases and burn your fingers. So better to give a trial of buccal, especially in young patients, which however may be the severity of the PVR, they tend to do well because the RP will be healthy. They tend to do very well with the buccal. So you should always give a trial of buccal in young patients.
Sir, if there is a subretinal band, then is only buccal sufficient, or
yeah, definitely in a pediatric patients, In spite of a subretinal band, it does settle. Unless there is a band running across the macula and causing a visual impairment, they tend to do well with, in spite of having a clear the subretinal bands, the retina tends to settle. Only the criteria here should be the break should be buckleable. Means the break should be anterior. That is the only criteria.
So a depressible and buckleable brake is what is the prerequisite for a
Yes.
pediatric.
Yes.
So if there are any more questions to sir?
The participants can also feel free to unmute themselves and ask. If there are no questions, sir, we can go ahead and sum up with a take-home message.
Yeah, the take-home message is basically you look at the age of the patient, location of the PVR,
Sir,
lens
what
status.
about the tamponade of choice? Like,
Yeah, there are, see, either you can use a gas. Sometimes nowadays we are thinking of a
sir, I have
short-term
one.
TFCL tamponade also, and you can use a silicone oil. Any of these things can be used.
Heavy density silicone oil, sir.
Yeah, if it is a one-eyed patient, inflammatory eye days, then you can use a 5000 centistokes oil, sir. You can use it. There's no issue with that. Densiron also you can use if it is available to you.
Thank you, sir. I think we can sum up, sir, if there are no other questions.
Yeah, sure. I thank once again the Preethi and the Education Committee for giving me this opportunity to talk on this useful topic. Hope I covered most of the aspects of the associated with PVR, and I clarified most of the doubts which are raised by the questions raised by the audience. So thank you once again, the committee, for giving me the opportunity. Thank you, Roshni, and everyone.
Thank you so much, sir. It was indeed a pleasure hearing you talk, and you are an expert in this field. Humbled by listening to you. Thank you so much, sir.
Thank you, Roshni. Thank you.